Thank you very much. And it's a real honor to be here at this year's West Coast Conference on Aging. And I'm looking forward to sharing with you a little bit what I've learned over the years about what we're liking to calling aging in the right place and how we can enable this with Canada's new long-term care standards. So I've got 3 presentation objectives for today. Number 1, we want to help understand how the pandemic and our experiences have influenced our views on where Canadians want to age. Number 2, we're going to then focus on appreciating how aging in the right place needs to begin with the development of age-friendly communities and more innovative and flexible models of community-based care. And then we're also going to look to understand how Canada's new long-term care standards, new national long-term care standards, can help enable aging in the right place. So let's give ourselves a little bit of context to begin. Right now, currently, 1 in 5 Canadians, or about 19% of Canada's population, are 65 and older, or as I like to say, 65 and better. And right now, that comes with great opportunities, but it also comes with challenges as well. For example, we read headlines each and every day about how Canadians are literally stuck in our hospitals. The numbers are around 7,500 Canadians on any given day, which represent about 15% of our hospital capacity. And it really talks about individuals who are stuck in hospital because they're actually waiting to go home with government-funded home care. They're waiting to go to a long-term care or continuing care home, or they're waiting to go to a rehabilitation center as well. The challenge is that while our population has changed, our system hasn't. And right now we haven't right-sized our system so people can get the right care in the right place at the right time. The challenge is that this is also costly for our overall healthcare system because the Canadian Medical Association has associated the annual cost of Canadians waiting to go elsewhere to be around $2.4 billion. And this is probably an underestimate of the overall cost of our system. So again, not having a well-developed system can actually end up costing us a lot more money as well when we don't get things right. The bigger challenge as well is that this is what our system currently looks like, but we know that within the next 10 years, our baby boomers are going to start turning 85 years of age in 2031. And by that point, 1 in 4 Canadians will be 65 and older. So we need to start thinking now and figuring out how are we going to meet the needs of our aging population over the coming number of decades as well. So I know it's the West Coast Conference on Aging, but again, this is an article that I like to share because it talks about Ontario's hospitals being unprepared for an aging population. But I'm sure you could easily say, I've probably seen this headline as BC hospitals or Alberta hospitals. Basically, this is a universal construct we're seeing across Canada as we increasingly hear about our hospitals are unprepared to meet the needs of an aging population and how we're often hearing that they're having challenges meeting their capacity issues because they have so many people living within them who are waiting for long-term care and other continuing care services as well. So the question becomes is how ready are we to meet the needs of an aging population, and what are the things that we can do to actually get things right? So we know that our experiences also shape our perspectives as Canadians. And when we start looking at what we've especially learned over the last number of years with the pandemic, we know that there are a number of truths that we have to figure out. We know that for many older Canadians right now, accessing long-term or continuing care services usually means having to leave one's own home or community to access those services. We also know that leaving one's community and being institutionalized and not being able to receive culturally safe and appropriate care close to one's family members and friends is an unfortunate reality for many people as well. We also know that there exists a universal desire amongst Canadians to age in one's own place for as long as possible. And so the question is, how can we actually enable this as well? So we also know that our realities need to be respected as well, because yes, while many Canadians live in urban centers as well, there are many who are in rapidly aging, smaller rural and remote communities who often don't have the same level of access to services. And we also know that small remote communities often do not have, don't have the support, can't support service and healthcare economies of scale. So they just don't have the sheer number of older adults to actually make, for example, building a large institutional long-term care setting, financially viable in the first place, or they'll have trouble even recruiting enough people to provide the care that they need. And so the challenge is, as long as we look at rural problems with urban solutions, we're also going to miss the opportunities that exist in smaller communities and in our own neighborhoods as well. As I mentioned as well, the pandemic really has shifted our perspectives as well. Our National Institute on Aging actually did a number of polls over the pandemic, and one finding that we found that was quite striking in work that we did with the Canadian Medical Association showed that 91% of Canadians of all ages and almost 100% of Canadians 65 years of age and older said that they plan on supporting themselves to live safely and independently in their own homes for as long as possible. So when we start thinking about what Canadians want, we know that there's a universal construct that people want to age in their own homes for as long as possible. This is a picture of Katie Krause, who's basically on your right here. She was a young trainee who was working with me with the desire to actually become a geriatrician, which she now has, and working in northern communities in northern Ontario, where she now has an active practice. And I used to do a lot of work where I'd fly up to northern communities. And I started this work after developing the Ontario Senior Strategy. And when I was doing that back in 2012, I met the lady in the middle here, and that was Granny Wabanow. Granny herself, at the time when I met her, was 106 years of age. She was the oldest person to participate in our senior strategy consultations, and she lived in a remote community called Moose Factory in northern Ontario. And when I asked Granny, what's important to you? What is important for you in senior strategy? She said, look, I live in Moose Factory. We're one of 5 small coastal First Nations, and we don't actually have, our communities aren't big enough to support long-term care homes, these sorts of things. She had worked for about 40 years as a midwife along the coastal communities, and she knew the value of being able to bring services to local communities so that people wouldn't have to be shipped elsewhere. But her biggest fear as she was aging, now as a centenarian, was that if she needed long-term care, she'd have to be shipped out of her community to Timmins or Cochrane, Ontario, which are hundreds of kilometers away. So the question becomes for her, she wanted to age in her own home for as long as possible. And that's what my patients in downtown Toronto tell me as well. And so we were able to actually set up services in Granny's community, training local folks to become personal support workers or healthcare aides, with the opportunity to allow them to be able to support her to actually age and die in her own home and in her own community, which is what she wanted as well at the tender age of 108. So when we start thinking about actually how do we enable the future provision of long-term care, we need to think about the importance of what that actually means. So back in 2019, our National Institute on Aging did a big national survey where we not only looked at what was happening across Canada, but we also looked at what's happening around the world, with the goal of focusing on how do we enable that future provision of long-term care. And what we also did was we actually looked at what services needed to look like, not only over the course of the upcoming across Canada, but also what and what they look like now, but what they need to look like over the next 30 years as well. And what are our projections for the needs of long-term care services over the coming decades as well. And so all of this together, more recently, we published a report that you'll see on your right called Aging in the Right Place, and really kind of helping to conceive what are the core elements that we will need to support older Canadians to live where they want. And all of this is part of a framing of what we call our National Senior Strategy. It really is an opportunity to look at how do we support people to live independent, productive, and engaged lives as older citizens? How do we support people to lead healthy and active lives across the life course? How do we actually support the development of more care that is closer to home, and so that people can receive care in their own homes or in their own communities for as long as possible? And how do we support our family caregivers as well, given that 8.1 million Canadians note that they're actually providing unpaid care for other older people? So when we also think about long-term care or continuum care, it's also important to think about what are the elements that actually really need to be thought about when we think about long-term care or continuum care. Because when you actually think about how we define long-term care or continuing care, if you look at places like Ontario or other places, often the legislation, the act, the programs or services talk about services that are really focused on care that occurs maybe in a long-term care or a continuing care home in particular. But really, when you actually look at definitions from the World Health Organization or OECD countries, we know that these services are often thought about really truly along a continuum. Doesn't actually matter where you live. It's the type of care that can be provided in your own home or an institutional setting. And so really, when we were actually looking to figure out what is a good definition, we looked at the OECD definition, the World Health Organization's even more broader definitions in the US, and we really came up with a definition that really helps to think about care that can be delivered, if you will, by paid or unpaid care providers, providing both ADL and IADL supports, care that can actually be provided in designated buildings, if you will, but also in home and community care settings, and also care that can also be not only responsive, i.e., care that is delivered if a person might actually need that care, for example, help with bathing or dressing, for example, but also care that's also preventive. How do we actually help a person not actually need to receive that care as well? And so really, when we think about preventative care, it could also be care that is what we call reablement, care that actually supports a person to receive that support if they, for example, suffer a disability and want to regain their ability to bathe or dress independently as well. When we think about aging in the right place, we often think about it as the process of enabling healthy aging in the most appropriate setting based on an older person's personal preferences, circumstances, and care needs. And not only do Canadians overwhelmingly tell us that they prefer to age and receive care in their own homes and communities for as long as possible, but it's often far less expensive than receiving care in continuing care homes as well. So actually, how do we actually enable this to happen? And when we think about the elements that are important in order to support people to age in the right place, we often think about these four key elements as well. How do we help Canadians and how do we help individuals promote preventative health aspects to help them stave off developing chronic diseases, but also support better chronic disease management so people can stay healthier and independent in their own homes and communities? We also think about the importance of strengthening home and community-based care and supports for unpaid caregivers as well. We also think about the importance of developing more accessible and safer living environments. And then finally, the importance of improving social connections to reduce social isolation and loneliness. So the challenge that we currently have too is this was data that we had from 2019 that really focused on the demand for long-term care or nursing home care in Canada. In 2019, there were about 40,000 Canadians who are waiting for care in nursing homes or continuing care homes as well. Now that number is estimated to be at over 52,000, with 40,000 alone just being in Ontario. But we also know that behind this number is an even larger number, almost 10 times the size, where we have about 430,000 Canadians telling us that they have unmet home care needs. And we know that if it's hard to actually meet your own needs in your own homes and communities, then it's only inevitable that you may not be able to stay in your own home for as long as possible, that you might actually be prematurely institutionalized. And currently, the Canadian Institutes of Health Information tells us that we actually have about 1 in 10 people entering a long-term care or a continuing care home currently who actually have, who are people who could have been supported to stay in their own homes for longer. So when we look at Canada as well, specifically in terms of how it actually ranks in comparison to other countries around the world, we also know that that when we look at Canada in comparison to other countries, we know that we are an underspender in terms of our overall GDP when it comes to long-term care services. If you look at this graph overall, you'll see the purple bar, which represents 36 OECD countries and the average spend of our gross domestic product related to the provision of long-term care services. And what you see overall is that that Canada is a little bit above average. You'll see Canada represented by the maple leaf, which is about 4 over from that purple bar towards the left. And you'll see that Canada spends about 2% of its gross domestic product every year on the provision of long-term care services. And that's the whole continuum from home and community care to nursing home services as well. But we also see that when you go further to the left, you've got countries like the Netherlands, Norway, Denmark, that's actually symboled by the little Danish symbol there, where you actually see that these countries are spending twice the amount that we are spending of their GDP on long-term care services, and a greater proportion of their overall total health spending on the provision of long-term care services as well. And so that's important to understand where Canada actually ranks, because we know that we spend less on average than some other major OECD countries that we like to compare ourselves. The other thing that is important to realize is where Canada actually spends its long-term care dollars as well. And we know that when you actually think about how we divide up our long-term care dollars between the provision of, say, home and community care, nursing home care, you see another story unfold. So again, to orient yourself, you'll see kind of towards the middle, you'll see that purple OECD bar in the middle, if you will. And that actually represents kind of, again, the average spending across 21 OECD countries. If you look towards the left of that, to the left side, you'll see the Canadian maple leaf, if you will, and you'll see a large amount of blue. That means that about 2/3 of our spending is spent on caring for people in long-term care or nursing homes, if you will. The purple bar represents spending on home care, which again, you can see is about 20% of our spending. And then what you'll actually see is this big gray bar in the middle between the blue and the purple there. And that actually represents spending on long-term care services in hospitals. And that's, again, represents those 75 to 100 Canadians on average every day who are living in our hospitals, receiving their long-term care services there, because we don't have enough services in their own homes and communities or in our nursing homes as well. But again, if you go over to Denmark, again, which is towards the to the right side of that bar, for example, you'll see that Denmark spends more than half of their spending on providing home and community care, more so than they spend on the provision of care in long-term care settings. And you can see they virtually have no gray bar in their overall ranking as well. And that's partly because they have so much home and community care and a right-sized long-term care system overall that they actually don't have this phenomenon of people waiting and living in their own hospitals, because they have actually right-sized their long-term care system to make sure that people have enough options, and especially the option to return to their own homes to receive their care there. This is another graph that I want to share with the group, because it also helps to contextualize what's been happening over the last 10 years. Because again, I started working on this with the Ontario government and other governments over the last 10 years, realizing the value and the importance of investing more in our home and community care services. And what you can see is this is a chart of Canada in terms of our spending on care in, if you will, long-term care settings, if you will. And then on the right side, you see spending on home and community care. And this is in the millions of dollars, if you will. And so what you actually see is that over the last 10 years, there's a good news story. We're spending more money on long-term care services today than we were 10 years ago. That's not a surprise. Our population continues to age. We want to try and keep up with demand. And what you see is that overall in Canada, what we've seen is an 80% overall growth in the provision of home and community care services. But we also see that there's been or an 80% growth in the funding on care in long-term care settings. But we also see that about 106% growth in funding for home and community care. So we're seeing a greater investment in home and community care services. But what I've shown you, as I've highlighted here for you, British Columbia, because what you can see with British Columbia in particular is that there's only been a 62% increase in funding for people living in long-term care settings, and an 85% increase in spending for people living in home and community care settings, which ends up representing less growth overall than what we've seen in Canada. But again, but still a challenge that we have in certain provinces and territories where there's been greater growth in institutional care funding than we have in home and community care spending as well. So we have real challenges here because we actually know what we should be doing if we look at good examples from Denmark and other places, but we're not making those accelerated investments, and especially those accelerated investments in the home and community care setting that could enable more people to age in the right place as well. As I mentioned, some of the work that we also did was actually helping to actually forecast what spending would look like over the next 30 years. And this is a chart that was developed by my colleague, Dr. Bonnie Jean McDonald, who is looking at what spending looks like now. The green and the blue sections represent public funding of long-term care services. The green sliver, if you will, represents spending around the provision of home and community care services. The blue section represents how we're spending the majority of our dollars on institutional care services. And this is basically a chart looking at what our future holds if we do nothing differently. If we keep funding an increase at the same proportional levels as we are right now over the next 30 years to meet the needs of our aging population. And what this predicts is if we keep doing the same things we're doing now, just at the same rate, we're actually going to triple our long-term care spending, or we'll need to triple our long-term care spending from $22 to $71 billion, to the point that by 2050, our spending on long-term care for our aging population will need to represent 1 out of every 5 income tax dollars. So that really tells you the basic point of this chart is to remind us that our current path, or our current format where we're preferentially having people live in long-term care or expensive long-term care settings can be really expensive, and it's not really financially sustainable. So then, of course, policymakers might say, well, we should just rely on families then. Families should be able to pick up the slack. Let's get, family members and friends just to do more care. Now, we have to remember here that if there's anybody receiving government-funded home care, about 75% of the care that those individuals are receiving in their own homes are actually being provided already by family members or friends. So we already neglect the fact that family members and friends are already providing the vast majority of home and community care or long-term care that older Canadians are receiving. But we also know that with declining birth rates and changing family structures over the next 30 years, we're going to see about 30% fewer close family members who are actually available to provide unpaid care for their family members and friends. And if we want to keep the level of family caregiving that's actually occurring today in our society 30 years from now, the remaining available family members are going to have to increase their productivity by 40% just to meet the future long-term care and unpaid care needs of their family members as well. So again, financially, this is not sustainable. Simply just putting this on family members and friends is not going to be sustainable. So we need to be doing things fundamentally different, and we need to be really rethinking our current approaches to care. So how do we actually enable aging in the right place? Well, this is a conceptual framework that I want to share with you, because this is something that we developed back in 2019 when we again surveyed the entire global literature and also great ideas that were happening across Canada as well to really help create this conceptual framework. And really, if you think about this kind of overall pyramid, if you will, and I'm going to go through each of these sections a little bit more on an individual basis, what you can see is this concept of thinking about people who are healthy and well, living independent in their community, all the way to people who have significant health and social care needs that might be living in institutional care settings. So thinking about that entire continuum of living, that entire continuum of actual complex needs. And then the blue represents a number of the models that we highlighted that exist here in Canada, in the United States, but around the world, that actually have good evidence to show that they can actually provide good, high quality long-term care supports in a variety of settings as well. So there's a lot of good evidence for a variety of services. Some of the things that we highlighted for those people who are healthy and independent, have very minimal issues or needs, are concepts like age-friendly communities. This is a World Health Organization movement, to try and promote the development of more age-friendly communities that allow people to stay healthy and independent in their own communities for as long as possible. We also think about interesting models like home sharing or co-housing. There's some really good examples of this that are being developed in British Columbia. And this notion that how do we actually support people to stay and to live in settings, for example, that allow them to feel confident and more able to live with just the support of other people around should they actually need it. We also think about the importance of home accessibility and modification programs that can allow a person to confidently age in their own homes should they develop mobility issues as well. And then we can also think about what we call enhanced home support programs. One of the programs I always like to highlight is the VIP program, the Veterans Independence Program. And this is a program that if you're an older veteran, for example, and you might need a little bit of extra support, things like a little bit of housekeeping, or you might need some laundry, help with laundry, for example, or some yard maintenance. This is where Veterans Affairs will provide those additional services that, again, can help a person confidently age in their own homes and communities and not have to think about leaving their own homes and communities as well. When we think about age-friendly communities or age-friendly cities, I want to share with you the World Health Organization definition because it really focuses on a community that recognizes the great diversity amongst older persons. It talks about promoting their inclusion and contributions. It respects their decisions and lifestyle choices, and it anticipates and responds flexibly to aging-related needs and preferences as well. And when we think about the concept of age-friendly cities or communities, we often think about, again, things like transportation, things like housing and outdoor spaces and buildings that are accessible. But we also think about the communities that we build as well. Are we being respectful and inclusive for older adults to be able to participate both socially, but also civically as well? And then how do we also think about that mix of community supports and health services that can allow people to stay healthy and independent in their communities for longer as well? When we think about supporting older adults with moderately complex care issues who are living at home in the community, we can then think about more intensive services that, again, might be that difference between being able to stay in their own homes, but also needing to move to a continuing care setting. So we think about the importance of community transportation services. We think about those that can actually help people get to appointments or still get around their communities if they're unable to navigate, say, public transit or drive themselves around, for example. We talk about in places like Denmark, they have programs that really emphasize that after age 75, everybody is automatically entitled on an annual basis to get a preventative home visit. It's the idea that a home care coordinator might visit you at home, check in on you, see how you're doing. And if you, for example, might be a bit lonely or socially isolated, they're going to help you get connected to a local program to support you in that way. They might help you get connected to local home care services or a Meals on Wheels program, but things that actually help you, again, get connected proactively so that you're not necessarily getting to a crisis situation where then everybody's trying to fix things and it may be a bit too late. The other program that really is popular in Denmark, but a number of other countries, is this concept of reablement. And this is the notion about how do we support older adults, for example, who might have had a fall, might have had a recent hospitalization, now have had some functional impairments, such as it's tough for them to be able to bathe on their own independently. And in these programs, what the home care program does is it doesn't just send a personal support worker or a healthcare aide to come in and help bathe you, but they also get you to work with a therapist, for example, who will plan a reablement program. So if they think that you have the capacity to maybe bathe yourself again on your own in future, not only do you get your bath, but then you also get a program of exercises that you will do with the goal that after maybe 6 to 12 weeks, you're able to bathe yourself yourself again, you're able to regain your independence. And we know that home care programs around the world that have actually created reablement as a core element of their home care programs, on average have been able to improve the availability of their home care services by about 10% as well. We also know that there's the importance of thinking about NORCs, or naturally occurrent retirement communities, and these programs. And this is about thinking about buildings or communities, for example, where there might actually be the majority of individuals living in these settings, or a significantly high proportion of these individuals living in these buildings who might be older adults. And how you can actually start leveraging this older population by bringing together services or programs that can help build community, but also maybe concentrate or provide more effective services like home care and other things that actually allow people to, again, live in these communities for longer periods of time. Across Ontario alone, we have 2,000 what we call NORCs. And I know in BC, there's some good work that's happening, around this idea of NORCs, and how do we actually look at programming and supports that, again, can help people who might be living in an apartment building or a community where there happens to be a high concentration of older adults stay healthy and independent as well. We also think about play. This is something that's become very popular in BC, Alberta, Ontario, but also other provinces as well over the last decade. And this is the idea of knowing that our paramedics are often responding to people who may have fallen, who may be suffering from very are not really well connected to other programs. By activating community paramedics in different ways, they often can identify people who might be struggling in the community and more proactively be able to work with them to get them better connected to the right supports and services. But we also have other examples where paramedics, for example, might be doing community wellness clinics in some of these NORCs, for example, identifying people who might have hypertension or diabetes and can get them better connected with their primary care providers or other healthcare providers in order to help get them the supports they need to help them avoid an emergency in future. And these programs are showing incredibly good levels of success, again, when we think about them as part of that broader continuum of care. When we think about people who might be what we call nursing home eligible, these are people who have significant complex care issues and needs and might, want to be able to live in the community, but only can do so with intensive supports. There's a lot of good models that are developing around the world as well. Some of the programs we look at are what we call supportive housing models. So people who might be living in a housing environment, but there's the availability, for example, of personal support workers or continuing care aides who might just be not only available on a scheduled basis to maybe provide a bath or provide some mealtime support, but they're also available in case there might be an issue that's unforeseen that happens at a different period of time where a person can live confidently, but access support or services should they need it. There's also adult day programs for example, people living with dementia, where people might be able to access those models of care as well, and a way that family members who might be working during the day can know that their family members are getting the supports they need, or even just a form of respite as well. How do we actually think about unpaid caregivers in these situations? Because we know that folks who are living with dementia, their unpaid caregivers might be providing 24 hours a day, 7-day-a-week care. And we know that significantly, this can be an area for burnout and caregiver distress. So again, there's some innovative models that have actually been developed to help give caregivers the training and supports they need to feel more confident about the care that they need to be providing, but also making sure that we're providing with the financial supports, the respite, the other supports that can allow them to be caregivers, but not necessarily burn out at the same time as well. They're great examples of what we call home-based primary care, more programs like hospital at home. And then one of the programs that I'm really excited about from the United States is a nursing home alternative care model called PACE, or the Program for All-Inclusive Care for Elders. We also looked at some similar models in Western Canada, like the PRIME model in Manitoba or the CHOICE model in Edmonton as well. And these are examples of models where nursing home eligible individuals can sign up for a program where, again, we wrap services around them at the same cost as what it would cost to care for them in a long-term care home, but allow us to deliver that care in the home with the support of primary care, home and community care, community support services as well. And by doing so, these programs in the United States have shown that after 3 years of enrollment, these nursing home eligible individuals, only about 15% of the individuals in these programs have ended up in a long-term care home. So again, reminding ourselves that often when we think about people who might be long-term care eligible, that doesn't necessarily mean that they can only live in a long-term care or continuing care home, but often we can actually deliver a broad range of services across the continuum when we have the right services and supports that are available. So what I want to say overall is that we have choices and options. And I think this is something that it's sometimes hard to fully appreciate, but I want to give you some of the numbers and share you the numbers that we have from Ontario as an example. I'm sure they're similar in Western Canada as well. But that cost, that daily cost of waiting to go elsewhere, so people who are waiting in a hospital bed, waiting to go elsewhere, is about $750 a day. We know that care in a long-term care home costs about $200 a day in Ontario. But we also know that the Ministry of Health in Ontario tells us that providing home care for a long-term care equivalent person, that might be 3 to 4 hours of care a day on top of the care that their family members might be providing, is about $103 a day. So you don't have to be a mathematician to realize that often providing care for people in their own homes is often much more inexpensive and more in line with what people actually wanted. And I kept mentioning Denmark a little bit earlier because, again, we've seen how Denmark spends almost twice what Canada spends of its GDP on providing long-term care services, but a much greater proportion of that care is now being provided in home and community care settings as well. And by actually shifting to this policy framework in the late 1980s, over the last 30 years, they've seen the ability that they were able to avoid building any new nursing home beds over 2 decades. And actually, believe it or not, they saw the closure of thousands of hospital beds by strategically investing more in their home and community care services. Because again, if we take 15% of our hospital capacity and we were actually able to fix it by providing people more care in the community that was appropriate for them, all of a sudden we'd improve our hospital capacity by 15%. And we may not need all of that to be providing acute care. And that's kind of why Denmark in many cases actually was able to close a lot of beds, because they no longer had an ALC crisis. They had to build more beds to accommodate. We also know that medical and technological advancements are allowing more people to be able to receive complex care in their own homes for longer. And if any of you follow the hospital home movement, I know it's something that's being developed on Vancouver Island, for example, and something the BC Ministry of Health wants to actually see expanded across the province. If you look in the United States, if you look in the United Kingdom, Italy, Spain, Australia, this is actually a model of care that's rapidly expanding, again, showing that we're even able to provide acute care in many cases in people's own homes. So again, how do we enable more aging in the right place with these technological advances that are now here today that may not have been there a decade or two ago? Of course, you might still be skeptical and say, is this even possible in Canada? Because again, here I've been talking to you about what's happened in Denmark, what's happened in other countries, and say, is this even possible? If we were to actually make more of those investments in home and community care, could we enable more people to age in their own homes for as long as possible? The answer is yes. I'm showing you data from Ontario between 2007-8 to 2016-17. And this actually represented the experiment that I convinced our Minister of Health back in 2012 to do. Because in 2011-2012, we said, look, we've got all these people who are waiting for long-term care. Should we be building more nursing home beds, or should we actually follow this Danish philosophy? And I convinced them to say, look at the data, look at what Denmark did. I think that there's so many more people who could be supported, who are long-term care eligible to live in their own homes, if we had more adequate home and community care available. And so what we did in Ontario is, starting in 2011-2012, is we started year over year increases by 5% of our home and community care budget. And by actually doing that, by expending more money on providing more adequate home and community care services, we were able to support more long-term care eligible people to live in their own homes. To orient you to this graph, you'll see this blue bar, which represents people who are 75 and older who are living in long-term care homes. That's almost literally everybody living in a long-term care home in Ontario. And that number was about steady between about 75 to 77,000 during this period of time. At the same time, you see the purple bars, and the purple bars represent long-term care eligible people who were being supported to be living in their own homes. And you can see between 2011, 2012 to 2016, 2017, that number increased from about 60,000 to about 90,000. So overtaking the number of people that we were supporting to live in long-term care homes. And actually, the latest data today that I just got from the Ministry of Health says they're supporting about 120,000 older Ontarians who are long-term care eligible to live in their own homes on an annual basis. And that number, that 76,000, 77,000 number has not changed overall. The Ministry of Health in Ontario also says that caring for that many individuals, that 120,000 long-term care eligible people in their own homes, costs the ministry in Ontario about $1.2 billion. Compared to the $4 billion it costs us to care for 77,000 people in a long-term care home. So again, you can see that there are significant cost savings when we actually look at leveraging more care in the community. The key is that we haven't been accelerating, as you saw, those investments as rapidly as I say that we should be as well. So I also want to talk a little bit about our long-term care standards, the new long-term care standards that you might be well aware of. So HSO and the CSA group work collaboratively on developing 2 national standards for long-term care. Many folks in the room are well aware of what we saw during the pandemic, where we saw that our long-term care homes were not well prepared across the country for providing excellent care, especially during the pandemic. And it really called into question, how well are we supporting our long-term care homes? How well are we actually funding and supporting the care that's actually occurring in those settings? So HSO developed its new national long-term care services standard to really focus around the care that is delivered in a long-term care home in terms of delivering safe, reliable, and high-quality long-term care services. And then CSA developed a complementary standard to really focus on the design, the operation of these homes, if you will, the hardware that relates to a long-term care home, where HSO worked on the software. What does the care look like in the home? And these 2 new standards were officially released at the end of January of this year. Of course, when you actually look at what does the HSO standard actually cover, when we talk about that care that's actually providing in a home, we talk about the standard providing guidance for long-term care home teams, leaders, and governing bodies, with guidance on providing that evidence-informed, resident-centered care that values compassion, respect, dignity, trust, and a meaningful quality of life. We talk about working in a team-based way to deliver high-quality care that's culturally safe and trauma-informed to meet the residents' goals, needs, and preferences. We talk about the importance of enabling a healthy and competent and resilient long-term care home workforce to enable a health and safety working conditions. And finally, we talk about upholding strong governance practices and a culture that's outcome-focused and committed to continuous learning and quality improvement as well. And so when you start thinking about these concepts, a lot of people, as we were developing these standards, or even when people were looking at the standards you're developing, said, are these standards exclusive to long-term care or continuing care homes? Because these standards sound like care that actually should be occurring in all settings, in home and community care settings, in retirement home settings, in assisted living settings as well. And we wholeheartedly agree. These standards are developed by long-term care residents and family caregivers, frontline workers, but also people who are policy decision makers and experts. And we agree that these standards can be the basis of the standards of care that we want to enable a healthy, competent workforce, but also that frontline care that we know is so important from a quality of care and quality of life standard. And if you want to learn more about the standards themselves, and again, the best evidence and recommendations that enable them, you can go to our website at www.longtermcarestandards.ca. And so can Canada's new national long-term care standards enable aging in the right place? Well, I think in particular, the CSA standard specifically notes design elements that can really enable less institutional settings of care, i.e. promoting more home-like care settings. And it really talks about the ideal future long-term care or continuing care home needs to focus on being more home-like, if you will, but also enabling people to have their own rooms, their own bathrooms that support even just better high quality of care needs and more privacy as well. The HSO standard also specifically calls out the need for appropriate staffing that will provide long-term care residents with at least 4 hours of direct care per day. Right now, we've now had Ontario, Manitoba, Nova Scotia that have committed to moving towards this level of care on a daily basis by 2025, by that year. And we know that the federal government has now made some significant investments, $3 billion to help support the provinces and territories over the next few years, implement these standards or achieve these standards, and an additional $1.7 billion over 5 years to support better pay and wages for frontline healthcare assistants or personal support workers to try and get people who are working in these important roles to at least a $25 an hour wage rate as well. So we can really enable a continuing care transformation. And I want to leave with these few points. Number one, enabling aging in the right place really requires a shift in traditional thinking. When we start thinking about where we were 10 years ago to where we are now, and frankly, where we need to go so that we can actually create a sustainable overall long-term care system for all Canadians, we need to really shift our thinking from more of an institutional focus to more of a home and community care focus. How do we enable aging in the right place wherever that needs to be? Not saying that one area of care is bad, but frankly, we haven't been enabling what people actually want and need and truly what is as possible. We also know that from enabling age-friendly communities to aging in the right place, we can create alternative housing options that can better promote independence, dignity, and respect. And finally, we need to think about innovative continuing care strategies and how they can succeed. Really, it's only through collaborations and partnerships that can really ensure the sustainability of our healthcare and continuing care systems for years to come as well.